let me talk to you about one more case. I talked to a number of you about adults. And I know some of you work with adults. How many of you work with adults here? Okay, a good number of people. Wow. So I have to give you equal time. What I'm going to show you is a case of an adult that I work with who was probably the most difficult person I ever had to work with. Took us the longest time to make inroads. Brings up a lot of different issues and questions relevant for children as well, because one of the issues that came up had to do with whether you can do one-to-one intervention when you don't have a lot of people. Okay, so not only am I committed to trying to come up with an intervention that will work outside in the real world, we need interventions that can be used in the real world when you don't have lots of one-to-one staff. So this is a case really that exemplifies how to intervene when you don't have a lot of trained people, you don't have a lot of people committed, you don't have a lot of time. Can you still do something meaningful? So that's what I want to show you. Let me show you just a brief clip of the woman who I work with first. This is, she was about 33 or 34 when I first had contact with her. She is a person who had one of those histories. You probably, if you've been in the field long enough, know that there is always a person in your county or a person in your school. You know, you mentioned about people being labeled. This person was known throughout the state because of her really lifelong history of self-injury. So she had a very long history of self-injury from the age of 2, the earliest documented records that she had been hitting herself. In fact, her grandmother was described as putting paper towel tubes on her arm so she couldn't hit herself. She blinded herself sometime in early adolescence by hitting herself so often, detached the retinas of her eyes. They thought that she was probably deaf. They couldn't really tell. She had a number of difficulties. What happened was she had this 30-plus year history of severe self-injury. In the past, they basically had tried everything that they could think of. I'll show you in a second some data from when they tried. They hired a consultant to come in to design a plan. They hired a full-time person to work with her to implement the plan. They put a lot of resources into this. These are the data from that plan. This was in the mid-'80s, I think. Baseline here is over 200. Notice this is hits per minute. So if you let her go, she'd hit herself pretty fast. Then they tried, I mentioned this before, contingent water mist. If she hit herself, again, this is mid-'80s, if she hit herself, they'd squirt her in the face with water. Now you could look at this and say, well, gee, it had an effect. Brought the behavior problems down here, a little bit of a problem here, and it actually, here it was ended. What happened was two things. First of all, it was a water spray. Notice this is about 25 or so sprays per minute. So she was wet all the time, and she started to become ill. The other problem was what these hits were hard hits. So she would do some of these, but then she would do some of these. And what happened was the water spray got rid of these, but not these. So what remained were the really hard hits that did damage. So at some point they stopped it as not being effective. And then they did helmet removal. They had, in the past, had put her in a motorcycle helmet, the face guard and chin guard, and she wouldn't hit the helmet. Okay, so what they thought was, well, maybe if we put her in this helmet and then take away pieces of the helmet that she wouldn't remember or she wouldn't go back to hitting herself. So what you see here is with one piece removed, another piece removed, and then as soon as they took away anything under her chin, she'd get in up underneath here and start hitting herself. So they stopped doing that. Then here is lemon juice. If she hit herself, they'd squirt lemon juice in her mouth, which is unpleasant. Behavior start coming back up. L stands for Listerine. I thought the Listerine people would be proud of that. Hits herself more, and then contingent ice. They would put an ice pack on her arm, which is unpleasant again. All different types of punishment programs they tried on her. So they stopped. This was after a number of months with a consultant, with a full-time person, number of months. And then about 2 years later, they did electric shock. Now, it's easy to kind of be easy to criticize them, but mid-80s, you've got someone who's blinded herself, who has been hitting herself forever, who has to be restrained all the time. You've tried everything. They tried all the medications that were available at the time. Argument was, and I could see it, if my child were doing that and a couple of shocks could get him to stop, I'd do it. Problem was, it wasn't a couple of shocks. So here, again, baseline, if you took her restraints off, she'd hit herself over 200 times a minute. With the shock, brought it down to about 100 times per minute. And again, these were tended to be the hard hits. And then they tried it, electric shock with DRO, meaning gave her orange juice if she didn't hit herself for a brief period of time. Then it was ended here primarily because a group came in and said you can't shock people so much, so often without their permission, so they stopped it. And then there was a hearing, and that's when I got involved, and they asked for a couple of pieces of information. One, did it work? Did the shock work? Two, if it did work, should they continue it? Three, if it didn't work, what should they do? Well, did it work? Okay, I'll be the judge now. Judge says, of course it worked. Brought it down by 50%. Then you could say, well, you shouldn't be shocking people. It's really not a good thing to do. He was not interested in that argument. What I had to argue was that when shock works, it works immediately. Meaning if you look at studies of shock, you do 1 or 2 shocks and the behavior problem pretty much goes away. This isn't going away. This is remaining. She's willing to be shocked 100 times a minute and still hit herself. What's going to happen next month and the month after when she gets used to this and her behavior problems rise again? Do you increase the level of shock? If you increase the level of shock, she'll get used to that. If she gets used to that, you have to increase it, and there's nowhere to go. There's nothing here. So we convinced the judge not to do anything, not to continue at least for a year. And he said, we'll give you a year to try something else. So what's the first thing you do? Who said that? I heard it over here. Who said assessment? Good work. Do an assessment. Why is she hitting herself? Now, when you ask the staff why is she hitting herself, they say, well, it's biological. You know, and you could get that feeling from her. If you took her hand out of restraints, her hand was trying to get to her head, desperately trying to get to her head. It felt like it was completely out of her control. Now, the one thing that you might have picked up from the restraint was when they put the restraint on, she could take her hand and do that, which meant she had some control over this. So it probably wasn't some involuntary movement that was biologically based. She could control it. So we did an assessment. We didn't do a functional analysis, meaning we didn't let her hit herself. We did the motivation assessment scale. And what you find is that when you do the motivation assessment scale, you don't get clear results because she hits herself all the time. So what we did then was broke it down into hard hits and light hits. So we did an assessment on the hard hits and an assessment on the light hits. The light hits came up as sensory. The hard hits came up as escape. And escape from basically anything. If you made her stand up, boom. If you made her sit down, boom. Anything would set off the hard hits. So what we did then was decided, okay, let's do something. We have a year, let's do something. Let's try to communicate for her to escape. So what you're going to see now is some of the first sessions I worked with her to try to teach the staff what to do. Now picture this. Because of all the legal issues involved, there are about 18 people watching and videotaping. No pressure. Oh, the other part of the problem was that they said that they were willing to do this, but that they were afraid that she would hurt herself if she were going to have to use her hands to communicate. And they said, well, you can't let her hurt herself. So we decided we were going to intervene while she was still in the restraints. she's in her chair, she's in restraints. I asked them for something, and they had a tongue depressor because they were in the hospital. Tongue depressor, put it in her hand, tapped her hand, she gave it back to me. That was the first step. Would she be able to give me something to communicate? You can imagine how much in awe all the staff were at this amazing intervention. It's like, what are we doing? Okay. Let me just show you what the data look like. Here again is kind of baseline without restraints, hits herself. This is during our training. What you see here, I'm not going to go into all the details, but basically different levels of training. So both hands in restraint, does she hand this to us? One hand out of the mechanical restraint, but we're holding her wrist. Then two hands out of restraints, both holding her wrist. And then both hands out of restraint, holding one wrist but not the other, letting it go. Does great when we do the training. So we were able to kind of go through this. Now, I mentioned the time factor. They gave her, we asked how much time could you do this? This is not all me doing this. How much time could you commit to working with her? And they said 20 minutes a day, 2 days a week. So okay, 20 minutes a day, 2 days a week, and ended up being 20 minutes a day, 1 day a week with people forgetting sicknesses. And I mention this because it's not like we had to work with her 24 hours a day with one-on-one, okay? That's all I had, so could we still do this? So this is 20 minutes a day, 1 day a week, basically, which was all fine, but actually outside of training, she was still hitting herself. So she was learning how to give this to us. She wasn't hitting herself. We eventually got both of her hands out of restraint. We weren't holding that. She would give us that tongue depressor thing, then we would put her back in restraint. That was all great, but whenever we took her hands out of restraint outside of training, she'd still hit herself. And then here, what happened was we changed it to involve iconic symbols. So we, instead of having the tongue depressor, we had a piece of leather that meant I want my restraint back on. We had a toy chair that meant I want to sit in my chair. So she could feel the difference and give us that. Once we did that, she started reaching in and handing it to us on her own, so without prompting. Once she started doing that, she started doing it outside of training, and she stopped hitting herself as much. So this is about a little bit more than a year after we started working with her. This is a year after that. This is in 1992. Yeah, so we take her out of restraint, and if she gave us a piece of leather, that meant I want my restraint back on. And that was usually her safe place, and that was fine. At this point, we started taking away the leather because she was out of restraints pretty much all the time now, so we didn't have that as an option anymore. But she could ask to sit in her chair, and eventually that meant I want to be left alone. So chair meant if I'm working, push me away. If I'm in my room, I just want to be left alone. She has had good times and bad times, sometimes with more hits, none with any injury to herself. Periodically, they have to re-teach her how to communicate with them. What they wanted to try to do was get her to use a toy toilet. That meant I need to go to the bathroom because she was schedule trained, but she wouldn't spontaneously communicate that when she needed to go. They never were able to do that, it just never worked. So they were able to teach her to give the chair, which meant I want a break. They were able to give her a toy cup, which meant I want something to drink, and she would reach in and give them a toy cup. She had a little apron that she would reach in to do that. She went from almost no time being worked with to being in pre-vocational skills training with everybody else there. And again, if she was working and she's had enough, she would reach in, give the chair, and they would push her back, and she'd be fine. So she's gone now 13 years without, well, almost 13 years, without restraints, without the medication. Took us a good 18 months to get her there. What's the point? The point is you can do this without having one-to-one, without having, the most highly trained people in the world, but you need to understand why it's happening. You need to teach some alternatives. You need to be patient. In the case of the Woman Pink, you need to have a lot of faith that this can work, and we'll make minor changes until we see some improvements. So even if you're in your 30s, even if you've had a many decade-long history, it's still possible to make some significant changes, and that's what we're doing.